Hi everyone, myself Dr. A. Mary Chandrika, Associate Professor from the Department of Biochemistry, Sree Balaji Medical College and Hospital. Today I am going to talk about fatty liver and lipotrophic factor. Why fatty liver? Fatty liver is becoming one of the most common non-communicable disease among our population. Talking about the epidemiology, 25% it is prevalent globally, 32% among Indian population. This fatty liver is mainly caused due to alcoholism. Apart from that, our non-alcoholic fatty liver disease is also becoming very common. There are many causes for this non-alcoholic fatty liver disease like diabetes and metabolic syndrome. This is highly prevalent in our population. So this NAFLD, non-alcoholic fatty liver disease, has been added in National Health Program in 2019 for prevention and control of various diseases such as diabetes, cancer, cardiovascular disease and stroke by the Ministry of Health and Family Welfare due to its higher prevalence. So we are going to see about it in detail in this session. Talking about the specific learning objectives. So at the end of the session, students should be able to enumerate the causes of fatty liver and describe the role of lipotrophic factors in the prevention of fatty liver disease. Liver is the central organ in lipid metabolism. So there are many metabolism which happens in the liver like fatty acid oxidation, triglyceride synthesis, lipotropin formation, cholesterol synthesis, ketone body production. All these metabolisms happens in liver and it plays a main role in maintaining the lipid content of the body. So what is fatty liver? It is nothing but excessive accumulation of triacylglycerol in the liver. It's coming around more than 5 to 10% of weight. What causes this fatty liver? One is excessive production of PGL. It happens during starvation and uncontrolled diabetes mellitus. Defective synthesis of lipoprotein or increased secretion of VLDL. What is the role of VLDL? VLDL helps in circulating the endogenously produced triacylglycerol from liver to peripheral tissues. So talking about this fatty liver, it is highly a reversible condition in early stage. So when it is diagnosed early, it can be reversed. This is also called as hepatic steatosis and it can progress to inflammation. That is, fatty liver can progress to steatohepatitis. Then it can end up in fibrosis of liver and cirrhosis of liver, finally liver failure. What happens in the liver cells? In a normal liver, Kupper cells will contain lipid droplets, little amount of lipid droplets, whereas in fatty liver, lipid droplets will be found in the entire cytoplasm of the liver cells. Coming to classification, fatty liver is mainly classified into two types. One is alcoholic fatty liver disease. The second one is non-alcoholic fatty liver disease. The causes for non-alcoholic fatty liver disease are: one is excessive carbohydrate intake, uncontrolled diabetes mellitus. Some of the toxin causes injury to the liver like carbon tetrachloride, chloroform, phosphorus, lead and arsenic. There are some drugs which affects the liver. They are corticosteroids, estrogens, tamoxifen, amiodarone and etc. Viral hepatitis like hepatitis due to hepatitis B can cause non-alcoholic fatty liver disease. Deficiency of lipotrophic factors also results in non-alcoholic fatty liver disease. Coming to causes of fatty liver, first is increased triacylglycerol synthesis. So when there is excessive mobilization of fatty acids, that is free fatty acids, non-esterified fatty acids from adipose tissue. Second is more synthesis of fatty acid from glucose. Second is reduced removal of fat from liver. This can be due to toxic injury to liver. So here secretion of VLDL needs synthesis of apoprotein B100 and ApoC. So then decreased oxidation of fat by hepatic cells also results in reduced removal of fat from liver. So the above factor, an increase in factor 1 and 2 or decrease in factors 3 and 4 will cause excessive accumulation leading to fatty liver. So coming to seeing causes in detail. First cause, excessive mobilization of fat. What causes this excessive mobilization of fat? When the capacity of liver to take the fatty acids from blood exceeds its capacity for excretion as VLDL. So this fatty liver can occur in diabetes mellitus, starvation due to increased lipolysis in adipose tissue. Talking about calorie intake, when there is an excess calorie intake, either in the form of carbohydrate and fat are deposited as fat. So hence obesity may be accompanied by fatty liver. The next cause, toxic injury. So already we have seen there are few toxins like carbon tetrachloride, arsenic, lead, etc. leads to injury to the liver due to poisoning by it. And this affects the capacity of liver to synthesize VLDL and leading to fatty infiltration of the liver. Also in case of protein malnutrition. So the amino acids which is required to synthesize apoproteins for this VLDL transport may be lacking. So due to this VLDL cannot transport triacylglycerol from liver to the peripheral tissue. So this TGL will be accumulated in the liver. Also hepatitis B virus reduces the functions of hepatic cells. So these are all leads to injury to liver. Another cause is impaired beta oxidation. So beta oxidation, when it is impaired, it leads to triacylglycerol accumulation. So this impaired beta oxidation reduces the liver ability to break down fatty acids in mitochondria. So also when there is mitochondrial dysfunction, it decreases the activity of enzymes involved in fatty acid oxidation, further limiting energy production. Also when there is carnitine deficiency, it prevents transport of long chain fatty acids into the mitochondria and it blocks the beta oxidation. Also we have seen alcohol metabolism. Alcohol metabolism increases the NADH-NAD ratio. It inhibits the oxidation pathway and favors excessive lipid synthesis. Altogether, these mechanisms reduce fat breakdown and promote fat accumulation in the hepatocytes and resulting in fatty liver. Another is VLDL formation. In our body, TGL is endogenously as well as exogenously transported. So exogenously is from our food. TGL is transported through the chylomicrons from intestine to peripheral tissues. Whereas endogenously secreted triacylglycerol are transported from liver to the peripheral tissue by this VLDL. So VLDL plays a major role in transport of triacylglycerol from liver to other tissues. So when this VLDL is not formed properly, it leads to accumulation of TGL inside the liver. So VLDL combined with TGL with apolipoprotein transports TGL from liver to other tissues. So phospholipids, especially phosphatidylcholine, are essential components of VLDL surface and help in proper assembly. Adequate proper protein availability is necessary for synthesis of ApoB100 and other lipoprotein components. So malnutrition is a common cause which leads to decreased synthesis of ApoB100. So here the lipotrophic factors come into picture. They are very important for production of this VLDL. Lipotrophic factors like choline and methionine, they support VLDL formation and are enabling export of TGL into circulation and preventing fatty liver. Talking about the most common cause, that is alcoholism, is one of the common cause of fatty liver and cirrhosis in India. So here alcohol is oxidized to acetaldehyde. So during this oxidation, there will be NAD will be converted to NADH. So when there is ethanol consumption, it leads to accumulation of fatty acids in the liver due to endogenous synthesis. So when NADH is produced more, NADH inhibits the oxidative pathway like fatty acid oxidation and TCA cycle. This leads to increased esterification of fatty acids in triacylglycerol. Finally, TGL will be accumulated in the liver. Now talking about non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, high fat diet, uncontrolled diabetes mellitus are the most common causes of this non-alcoholic fatty liver disease. When this NAFLD is not treated, it leads to non-alcoholic steatohepatitis. That is a more of an inflammatory condition. So again, when this NASH is not treated, it will result in cirrhosis and liver failure. So how this fatty liver progresses? So as already we have seen, liver cells will have fat droplets inside the cytoplasm. In fatty liver, the cytoplasm will be having more of fat molecules. These fat droplets merge together and occupy the entire cytoplasm. Now this due to this, the nucleus is pushed to side of the cells and nucleus further disintegrated. It is called karyohexis, and ultimately the hepatic cell is lysed. So when this lysed will undergo healing by fibrosis. So when this fibrosis is extensive or it affects the entire liver, and it is also known as cirrhosis. And finally, this cirrhosis will result in liver failure. This can be investigated by doing liver function test. So this liver function test will show abnormal OTPT values. Now, how can we prevent this fatty liver? It is mainly by the use of lipotrophic factors. What are lipotrophic factors? They are factors which prevent and cure the accumulation of abnormally large amounts of fat in the liver. So deficiency of this lipotrophic factors will result in fatty liver. So some of the lipotrophic factors are choline, methionine, inositol, betaine, vitamin B12, folate, which has an indirect role, lecithin, omega-3 fatty acids. What's the role of choline? So what is choline actually? It is an essential nutrient and a key component of phosphatidylcholine, which is an important phospholipid in cell membranes. So this phosphatidylcholine is crucial for the assembly and secretion of VLDL from the liver. So adequate choline ensures proper packaging of TGL along with ApoB100 and helps in transport of this package into the circulation to peripheral tissues. But when there is a choline deficiency, it impairs VLDL formation leading to reduced lipid export, and due to which this TGL will be accumulated in the liver cells, that is hepatocytes. There are some sources for this choline like egg yolk, liver, meat, fish and certain legumes. Coming to talk about the next lipotrophic factors, that is methionine. It is an essential amino acid, like it is a sulfur containing amino acid, and it must be obtained from diet, and the sources are meat, fish, eggs and dairy products. So this methionine, it acts as a methyl donor through S-adenosyl methionine, that is SAM, which participates in important methylation reactions in the body. Through this methylation reactions, this methionine helps in synthesis of choline, which is a key lipotrophic factor. So methionine is needed for choline formation, and choline formation is needed for VLDL formation and assembly. Thus, sufficient methionine intake prevents TGL accumulation in the liver and prevents from fatty liver. The third lipotrophic factor is inositol. It is an important component of phospholipid, that is phosphatidyl inositol, which is present in the cell membrane. So what does it do? It supports the lipid metabolism and it helps in proper transport of lipid within the body. So adequate inositol helps in synthesis of normal VLDL and normal VLDL formation and secretion from the liver. So deficiency of this inositol leads to impaired lipid transport mechanism, leading to accumulation in the hepatocytes. What are the sources of this inositol? They are cereals, whole grains, nuts, fruits and legumes, few legumes. Now talking about the clinical features. Early early NAFLD or fatty liver will not have any symptoms. They often remain asymptomatic. But later on, when they enter the stage 2, there might be mild hepatomegaly. The persons will present with fatigue. They might have an associated metabolic syndrome. And later, when this fatty liver progresses to NASH, it results to abnormal liver function test. So we need to investigate liver function test where that will include serum ALT and AST. There will be elevated triacylglycerol in the blood. Increased fasting glucose, insulin resistant markers can be done to rule out metabolic syndrome. Ultrasound should be done to find this fatty liver. And the gold standard is liver biopsy, but it is an invasive investigation. So we can find using an ultrasound. So how can we prevent this fatty liver? So main is balanced diet. Diet which leads to increased TGL has to be reduced. Adequate protein intake should be maintained. Lipotrophic nutrients should be added in our diet. Regular exercise should be done, and we should avoid excess consumption of alcohol. Coming to treatment principles, first is of course our weight reduction. Second is control of diabetes and prevent ourselves from development of metabolic syndrome. We should manage dyslipidemia, should undergo lifestyle modification like diet as well as exercise, and we should avoid hepatotoxic drugs. So these things will help in prevention of this fatty liver in our society. Thank you. To conclude, fatty liver is mainly due to accumulation of triacylglycerol in the liver. This is mainly caused due to imbalance in lipid metabolism. Alcoholism plays a vital role in causing this fatty liver. Nowadays, even non-alcoholic fatty liver disease is becoming very common, causes due to metabolic syndrome. And insulin resistance here plays a key factor in causing this non-alcoholic fatty liver disease. Lipotrophic factors play a main role in preventing this fat accumulation, and we should know early stage is highly reversible. So finding the fatty liver at the earliest, we can cure it. But in later stages, this treatment is highly tough and it might land up in liver transplant.
you.